Well, good day. Welcome to Come Let Us Reason Together, the podcast and video chat for Come Reason Ministries. My name is Lenny Esposito, and I've been part of Come Reason for 20 years now. And I have a very special guest today, a good friend, someone I'm very excited for all my viewers to meet, Dr. Ann-Jeanette Roberts from Reasons to Believe.
Hi, Lenny.
Now, how are you, Ann-Jeanette? Nice to see you, AJ.
Good, and you can call me AJ. Yes, please.
Yes.
Yeah.
Most folks may not know AJ. She's kind of one of the hidden secret powers, if you will, at Reasons to Believe. She's a molecular biologist. Got her BS in chemistry through the University of Tulsa, PhD in molecular and cell biology through the University of Pennsylvania in 1996. She did postdoctoral research at John Rose's lab in Yale University. And more importantly, to our conversation today, she did research on SARS-CoV-1 between 2003 2006 at the National Institutes of Health under Dr. Kanta Subbarao. Am I saying that correctly?
No, that's okay. It's really hard. It's
Kanta
Subbarao.
Okay. Kanta Subbarao, got it.
Subbarao.
But there you even won the NIH Merit Award in 2005. So you're familiar with coronavirus. You've lived in this world for some time, and I think that's very cool. You're also writing on issues of science and scripture and how you can share the news of hope, forgiveness, new life, and truth. And you have a book you're working on right now as well, if I remember right.
Yes, I do. And the book is Thinking About Evolution, 25 questions Christians want answered. So there's a little bit about viruses in there, but not much.
Okay. Well, all that is to say, you've had some definite dealings with the coronavirus issue. I'm sure your phone is ringing off the hook. So what I want to do is just talk a little bit about SARS-CoV-2. First of all, a review of what it is, where it came from, and why it's different than maybe other viruses, the flu, things like that we've seen. Why is it raised to this level of concern? So.
Wow, those three questions you just asked could take an entire hour to address. See, what is it? It's a coronavirus, and most people probably don't know exactly what a coronavirus is. But to people who study viruses, to virologists, if you say something's a coronavirus, we already immediately know a lot about it. We know that it has a genome that is an RNA genome. We know that its genome is one piece and very, very long. In this case, it's about 30,000 bases long of what's called positive sense RNA. And the reason it has a designation of positive sense, it means that the RNA could function as messenger RNA. And if you'll kind of clear the cobwebs back to biology, in order to get to the protein phase of the molecular biological process, you start with DNA typically. The DNA has an RNA intermediate that's called messenger RNA, and then that messenger RNA is translated by ribosomal structure into protein. And so what the positive sense RNA genome tells you is that genome is in the same sense as message. And so proteins can be read directly off of the genomic RNA that's part of the virus. We also know that it's a big virus that has proteins around the nucleic acid, and then has a membrane covering that's derived from the cell that has viral proteins that are inserted or stick through that membrane derived from the cell. And so those proteins that stick out onto the surface are called spikes, and they actually give the virus the appearance of sort of like a little miniature sun underneath an electron microscope. And that's where it derives its name from, corona or crown. The outside of the virus looks a little bit like a crown, like the sun's corona as well. So that's immediately what we know about what the structure of the virus is, if you say it's a coronavirus. We also know, if you say it's a coronavirus, that the likelihood of it being a respiratory virus is very, very high. But it's also, if it's a coronavirus, it may have about a 30% impact in something called enteric infection, which is an infection of the gastrointestinal tract.
Oh, okay.
Respiratory diseases or GI. We also know, if you tell us that it's a coronavirus and you call it a SARS coronavirus, that it's going to share a lot of similarity with the first SARS coronavirus that was ever identified on. That's the one I worked on at the National Institutes of Health. And that caused a very small outbreak in late 2002 and the first part of 2003. An 8-month period where globally 8,000 people were infected. It was dispersed to 27 different countries, but primarily in Southeast Asia, China, and sort of a local epidemic outbreak in Toronto. But of those 8,000 people that were infected the first time, about 800 people died. And so a case fatality rate of 10%. And the case fatality rate indicates how many people were infected and what percent of those people had a fatal outcome. And so a 10% fatal outcome, or CFR, for SARS-1. I'm teaching you that so that when we start talking about SARS-2, you'll know what I'm talking about when I say CFR. Let's see, what else do we know?
SARS stands for it's an acronym for?
It is an acronym for severe acute respiratory syndrome.
Yeah.
And so it's unlike other respiratory viruses, especially unlike influenza virus. And I'm going to actually hammer this home in just a second. But it's very, very different than influenza virus, even though both of them can cause a respiratory infection and can lead to severe cases of pneumonia. Coronaviruses that infected the human population before the first SARS, we only knew of 2. And they have really strange names, OC43 and 229E, and they're both associated with the common cold. And so if you have a cold, there's about a 30% chance that the virus that's causing your cold is one of those 2 coronaviruses. When SARS emerged in 2003, we were surprised that it was a coronavirus. The disease that it was causing was very indicative of influenza and severe cases of influenza. And we thought, well, this must be another flu virus. And it wasn't. And it had us puzzled for a while. And we finally identified it as a coronavirus, and we thought, well, that's really strange. We don't typically associate coronaviruses with this type of severe outcome. And since then, in 2012, there was also a virus called MERS, which is also a coronavirus. And it has a case fatality rate of almost 35%. And so it's really very scary.
Wow.
The first SARS came from bats through an intermediate host, a weasel-like animal called a civet cat, or just a civet for short. MERS came from bats through an intermediate host, the dromedary camel. And so MERS has been found in the Saudi Arabian Peninsula, and there's also been a bizarre, also local outbreak in Korea. And it's reemerged time and time again since 2012. But SARS, the original, if you will, and MERS, they've not become pandemics because they haven't been able to be transmitted easily from human to human. And so that's in stark contrast to this one that we're facing today. This one has very easy spread from human to human, possibly even twice as more efficient as influenza in being spread from person to person. And so, so how is it not like flu? Or wait, should we answer the question maybe where did it come from first? Well, like the other 2 that cause severe respiratory distress and can lead to a high level of fatality, this virus also originated in bats. The big unresolved question in the scientific community at this point in time is, did it come directly from bats into humans, or was there an intermediate host? And some people have speculated that something called a Malaysian pangolin, and I can't even tell you it's a weasel-like animal. I've never seen an animal that looks like a pangolin before. Maybe you should Google that and take a look at what a pangolin looks like. There's some speculation that maybe it passed through a pangolin, but we don't have the same confident amount of data that would verify that route of emergence into the human population. Now, the question is, if it came from bats, did it come from bats in nature, from animal traders who were going out to trap bats and then take those bats to live animal markets where they maybe come in contact with other animals, or the traders or consumers or handlers at those markets? Often animals that come from the wild and are delivered into these exotic meat markets or wet markets, they're all the same thing in these southeastern countries. they get crowded together with other animals that they normally wouldn't encounter in nature. And in those crowded environments, you also get human interaction. And so it's sort of a giant scale petri dish for what we observe in the laboratory to happen sort of in the immediate environment. These coronaviruses can recombine with other coronaviruses. They can kind of swap genetic information with one another. And sometimes they accrue mutations, just simple mutations through mistakes in replication. And those mutations can allow a coronavirus that normally wouldn't infect people or infect an intermediate animal like a civet or a camel or something to that effect. Those mutations can allow what we call species jumps. And so that happens with influenza too, right? We had the swine flu of 2009. Influenza came into pigs and from pigs into humans. And so there are mutations going on at the genetic level of the virus that allows it to make these species jumps. And so the question is, did that jump happen directly from a bat into a human this time? Or was it a bat into some other animal and then into a human? And then the other unresolved question is, did that happen in nature? Or did that happen in a research laboratory in Wuhan where they do coronavirus studies and they actually have lots of bats in cages? And you know, when I worked at the National Institute of Health, I tell you, the most stringent containment protocols were followed when you work with a virus that's classified as a biosafety level 3 virus, which is what SARS and SARS-2 are. Actually, I don't even know if SARS-2, the one we're facing now, COVID, will be a BSL-3 biosafety level 3 agent, or if it will actually end up being a biosafety level 4 agent, which is even more extreme. That's the one where you sort of have to have on almost like spacesuits with the you know, when you saw Ebola or right. Contact or something like that. Ebola is a BSL-4 agent. SARS, the original, was a BSL-3 agent. And when we worked with that at the NIH, the containment facilities and the protocols that we had to go through to work with the virus safely, if those aren't followed diligently, religiously even if you like, then there is real personal risk for both the handler or anybody who works in the lab to become infected, especially if it's easily transmitted through contact like SARS coronavirus is. It can enter the portal of your nose or your eyes or your mouth. And this is one way that SARS is not like flu. To get the flu, you have to pretty much breathe the flu in, or you have to possibly come in contact with contaminated surface and get it into your respiratory tract. With SARS, it doesn't have to enter that way. And with flu, once it's in your body, it has what's called tropism. Tropism is where does the virus go once it's inside your body? It infects the bronchial epithelial, which is the lining of your bronchi, your esophagus, not your esophagus, but the part that you breathe through, that tube. And it infects the lung epithelial cells as well. And it can also infect the lung cells, something called a pneumocyte. That's how most respiratory viruses set up infection, is they infect the epithelial cells and possibly the lung cells or the pneumocytes. With the case of SARS, flu is localized to the respiratory system. With the case of SARS, it's not. SARS can go on to infect your liver, your kidney, your heart, your intestines, and in very rare cases, SARS can even cross the blood-brain barrier. And so we see a lot more severe disease in those who become symptomatic, and that's another big difference, right? With the first SARS and with flu, the first SARS, you usually became sick within 5 days. And we don't know of much, if any, asymptomatic cases in the first SARS outbreak. So pretty much if you were infected, you became symptomatic, and you became symptomatic on average within 5 days. With flu, most people become symptomatic within the first 24 hours. And so with this one, at least, and I'm going to say at least 30%, although the number is probably much closer to 40% at least, maybe up to 60% of people who are infected are asymptomatic. They don't even know they're sick. They have no symptoms that make them feel, no symptoms that we've noted yet that make them feel like they're sick. Why did I say that we've noted yet? Well, because some of the recent data is suggesting that your oxygen levels in your blood may change. And most of us may not feel that or notice that if they're just changing a little bit. But if your blood oxygen level drops below 94%, your body is starting to become oxygen deprived. And the lower it drops, the more critical you become. And so that's what's happening to many people who are ending up with pneumonia and having to go on to ventilators, is that their blood oxygen levels are dropping so quickly and so severely. So if we were actually checking our blood oxygen levels, those little cups that they put on your fingers at the doctor's office, and it reads out a number that's usually around 95, 96, 97%, that's telling you your blood oxygen level. Well, if you were doing that twice a day, every day, and you saw it start to drop and it dropped below 94 and it stayed below 94, again, you may not necessarily feel anything, but that might be an indication that you were sick. And so, so that's how's it also not like flu? It's also not like flu in its stability outside the human body. So flu is pretty wimpy. SARS is pretty hardy outside the body. And so things that would typically inactivate the flu virus will not necessarily be as efficient in inactivating the SARS-2 virus. And so will it be seasonal like flu is? We're pretty confident, and who I mean by we, people in viral epidemiology that work for the Center for Disease Control or other public health institutions, both nationally and globally, virologists who understand respiratory viruses like the flu and like SARS, other individuals who follow who follow sort of infectious diseases.
Yeah.
These are the people I'm talking about when I say we. Okay, I don't just mean scientists. I don't just mean doctors. In fact, I probably more often mean scientists than doctors, even though the public may think of the two synonymously. And certainly public health officials that are trained in viral epidemiology. These are the people I mean when I say we. So we definitely don't think that SARS will be seasonal to the same extent that influenza is seasonal.
Okay.
And we think that for very specific reasons. One is it has been in the southern hemisphere, which it's been their winter. It's been there and it's been transmitted from human to human during their during their summer months. In the southern hemisphere, it's been summer. Right. And so it's been in the southern hemisphere where it's summer, and it's already and has been sustained in human to human transmission. And now that they're moving from their summer into their winter, as we're moving out of our winter into our summer, we're actually starting to see case increases. And so that spread from human to human is ramping up in the southern hemisphere right now. We're seeing it in Africa, and we're seeing it in other southern hemisphere countries. So that's why we definitely don't think it will go away in the summer, because it was already present there in their summer, and now it's taking off now that they're in their winter. Another reason is that you may have heard that the SARS virus is sensitive to heat and humidity. Well, it is, but not to the extent that you've probably been led to believe. So there were experiments done on the first SARS virus because it disappeared in July. And everybody speculated, why did it disappear in July? Was it because we encountered summer temperatures and summer humidity? And so people went in and they did those experiments. And what they found was if you have a high temperature, 100 degrees or warmer, and if you have a very high humidity, 95%, or greater, and you have that for a long period of time, at least 11 hours to 24 hours, what happens to a sample of the first SARS coronavirus? If you have a sample of 10,000 virus particles and you subject it to 100-degree heat, 95% humidity for 11 hours, and you go in and you measure, okay, I started with 1,000, how many do I have now? The answer is 10. If you go as short as 7 hours, or if you go as low as 90% humidity, or you go as low as 90 degrees Fahrenheit, you go back to that same sample and you ask how many of those 1,000 particles do I still have left? The answer is probably about 800 or 900. So there is some susceptibility to temperature and to humidity, but it has to be high, and sustained. And if it's not all three of those, then you may be losing some of the infectivity, but you're probably not losing all of it. And that mirrors what we've seen in the southern hemisphere in their summer months. It's there, it's sustained, but it's probably hasn't been transmitting as easily as it has been in the northern hemisphere where the temperatures have been colder.
Well, that's a whole lot.
It is. Like I said, you asked me a lot of questions.
Yeah. Well, so let's get it, because we've lived with this for about 6 weeks now in the U.S. Obviously longer in Italy, other portions of the globe, and people are starting to get restless. They're starting to say things. Well, if it's asymptomatic, does that mean that a lot of people who get it really don't have to worry about their health per se, because it's really not going to affect them much?
Yes, it means that, but we don't always know who those people are going to be, right?
Well, and this is one of the frustrating things I think about this, because really, when you in a scientific context, our data is severely limited right now. I mean, we just don't, it takes time to understand how these things work. The only closed case study that we can find is maybe those folks who are on the Princess Cruise Line, because that's a kind of a self-contained, isolated incident. But it's such a small sample size. I don't know if that's going to be indicative of, what the general population is going to assume. So what do we do? I mean, there's been a lot of models. Some of the models have vastly overstated what they thought. Other models have said, no, we believe we're right, but because we have self-quarantine, we've locked down, we've really flattened the curve.
Yeah.
So how do you deal with a dearth of true data, but still trying to make only go as far as necessary for folks to live and thrive?
Man, Lenny, what great observations, and what a great conglomeration of factors you brought up as you were describing the situation, right? So one of the other things that maybe was or wasn't apparent is that, the level of crowding is also very important. And so
good point.
We have this idea of social distancing, and many of us who don't really understand what we mean by different phrases or precision of language is we equate things like social distancing with self-quarantining. And it's like, those are two very, very different levels of public health intervention, right? As is isolation. Isolation is very different than social distancing. And so the vast majority of the US has been asked to shelter in place, stay at home, but go out if you need to. And if you go out, try to maintain social distancing. And if you can't maintain social distancing, and now it's actually saying, even if you can maintain social distancing, if you're going to go out, wear a mask. And the mask isn't to protect you, but if everybody is wearing the mask, everybody is protected, right? The mask is to keep your breath from traveling out to others, because your breath is full of very small respiratory particles. And you can see how this is true if you just take your cell phone and you hold it up and you talk, and then you pull it away after you've said a few things. You can see that there's humidity that forms on the cell phone. Well, those are very tiny respiratory droplets. And the travel distance for those small particles is about 6 to 8 feet. That's as far as they'll go. They'll go about 6 to 8 feet before they sort of drop away, and gravity or the airflow takes them in other directions. And so that's why we social distance to 6 feet. You don't even have to be talking. You certainly don't even have to be coughing. You can just be breathing. Same experiment, just breathe. And those respiratory particles are still coming out of your mouth. So if you've got a mask on, it's keeping your respiratory particles from your breath traveling out to others. And so that's preventing it from landing on surfaces, which means, I don't have to worry about touching a surface and then touching my face. And I also don't have to worry about breathing if I'm around you, because your breath is being contained.
Right.
And so we say it's so asymptomatic people won't be spreading it to others. Well, truth be told, even if you're symptomatic and you have a mask on, you're going to prevent you from being able to infect others easily.
For the most part.
For easily, right? So yeah, for the most part. And so I definitely think, Lenny, that the shelter in place or the social distancing advice is advice that we needed to implement, and we needed to implement it quickly, and we needed to implement it widespread in the US while we were still in flu season, because flu season puts a burden on the hospital system and hospital resources. And we have flu vaccines, and we have drug treatments in the first 48 hours, and we have baseline immunity to flu in the general population. And so we have a much less national and global susceptibility to influenza than we do to SARS-2, which none of us has ever seen before. 100% naive population, right? And so, and if it is passed more efficiently from human to human than flu is, then it can become a really severe problem very quickly for many millions of people. And we don't want that to happen when we're already, and this past flu season has been a near epidemic level flu season.
Really?
And we've been 0.1% off of it being an official epidemic season. And so during the height of the flu season, we had hundreds of people per week that were dying. And so that was the third and fourth week of January and the first week of February.
Okay.
So we had a very severe influenza season going on as we're beginning to learn about COVID. And so public health officials who understand epidemiology and who understand public health dynamics and viral transmission of respiratory diseases were severely panicked, even though they didn't come out in public in a panicked tone. They're trained professionals. They were panicked because if we have a totally naive population that's going to be contacting something, at that point we thought it was probably as infectious as flu. But we already knew at that point that it had the potential to have a much higher case fatality rate. The case fatality rate coming out of China was significantly higher than the annual influenza fatality rate. And then when it got to Italy, oh my goodness, we started to really worry. And we, again, being public health officials and virologists. And it's like, we absolutely have to social distance. We absolutely have to self-isolate, especially the most vulnerable. And again, the original data was if you're older and if you have comorbidities or other underlying illnesses, you're more susceptible. And we kind of got misinformation that younger people were probably invulnerable, and we're learning, well, that's definitely not true. We have some cases of people under 40, otherwise seemingly healthy, who have gotten this and who have actually died of stroke. We don't understand the mechanisms underlying that yet.
Yeah, I saw that.
Yeah, so there's still, like Lenny said, we are still in the process of learning about an unknown pathogen that we've never encountered in the human population before as the pandemic continues to unfold. Back to Lenny's question about the modeling, it's like we do our best, and all when you take the data you have at hand and you build epidemiological models. And what those models were definitely telling us early on was if we don't intervene through stay at home, self-isolation, social distancing, and as soon as we learned about asymptomatic cases, we started to say wear a mask if you're going out, in addition to social distancing. So all of those have been unfolding as we've learned about the pandemic, as we've learned about spread to spread, as we've learned about the viral biology and pathophysiology, the disease response, as we've observed more and more people getting infected. One of the other things that we've never seen before that I think is totally fascinating, knowing what I know about the biology of the virus and the way that it infects animal models, is we now have so many people infected. We now have a new symptom associated with this virus, the sense of losing your sense of taste and smell. And it's like, that's fascinating to me as a scientist who studied the original SARS virus. We only had 8,000 people infected at that time. Did they have some of the same symptoms and we just didn't notice it because out of those 8,000 people, nobody said, oh, by the way, I lost my sense of smell and taste. But now we're seeing that that's a pretty common symptom. And so as we learn globally, right? So as the professionals are learning, we're disseminating the information and the media is sharing that in addition to some other really hyped up information. So I want to come back to the origin of the virus because there's been some speculation, maybe not on mass media like local or national news networks, but certainly on social media about conspiracy theories that this is a human construct. And I can tell you that I and a small group of scientists and many other groups, two of which have actually published their results, have gone in and looked at the viral sequences, which is one way that you can try to determine if something was constructed in a laboratory by human engineering. And all of those studies all of those studies to a T have said no, there is no sign whatsoever that this was a human construct. So we didn't go into the lab, scientists, counterparts like us, either in the US or in China, and that's been part of the conspiracy theory. Oh, this virus started in the US. No, it didn't. It started in China. It almost certainly started in China. The question is, did somebody design it as a bioweapon in China? And the answer from the scientific evidence from people I trust because I've been a part of that, people I trust because I know them, they're coronavirus virologists that have been in the field for 4 or 5 decades. What they're saying is we've looked closely, we've looked with great scrutiny, and there's no sign that this is a human construct. Again, that doesn't help us discriminate between, well, was it a laboratory accident where somebody in a Chinese containment facility wasn't careful and somehow the bats they were working with transmitted a virus to a human, and that human may or they may have been symptomatic and gone out into public and spread it. That's going to be a very difficult discrimination to make if it originated in nature or in the lab, unless we can go out into nature in China and serosurveil. That's a way of looking at the blood for antibodies in animals and looking at the blood for virus in different animals. Unless we can go out and widely serosurveil the animal populations in that area, if we find a virus that's more similar to the one that first appeared in humans this go around, or if we find one in another animal that's an intermediate between the closest one in a bat right now and the one that we find in the early cases of human isolation, if we can find one of those two things, then we can say, no, look, there's really good signs in nature that this happened in nature, right? And so we can get that kind of information.
Right.
Or we can have somebody from a Chinese lab come out and say, oh, we think we had a laboratory accident. Yeah, I don't think that's going to happen, even if that happened, right? So, yeah.
Wow. So let me ask you a couple of questions. First of all, what are the latest estimates on the CFR? Because it's been reduced down. I know that there's some say it's 1%. WHO reported it was 3.4% in early March, but we're now into the late April. So
let me answer that question. And there's a lot of factors that go into the CFRs. If you just look at the reported cases, so you're talking symptomatic cases, which is all we knew about for the most part until we started to get antibody tests and realized there was asymptomatic infections happening. So if you look at cases and looked at case fatality rate early in the epidemic. So I started following the numbers around the first week of February. And around the first week of February, the CFR globally, and primarily it was just in China, it was in South Korea in February, it was in Italy and Iran in the latter part of February. But if you started following those numbers in February, the CFR was between 2 and 3%. And it stayed between 2 and 3% for about 3 to 4 weeks. And then it crept up and it stayed between 3 and 4% globally as it continued to spread. It stayed between 3 and 4% for another 3 weeks or so. And then it crossed the 4% line. And then it was so widespread. And we realized there was about a 2-week lag between case reports and fatality reports. And so even if all of the case, like no more new cases developed today, we might still see increases in the fatality rates for another 2 weeks. And that's because of the incubation period and the course of disease and how long it takes somebody to progress to a fatal outcome. But anyway, so considering all of those things, what we know now is we can't with any definitive confidence what to see in any local place, because there are so many asymptomatic cases, because we don't have widespread testing both for the virus and for antibodies to the virus, which indicates somebody's been infected and they've cleared the infection. And until we have widespread testing of both kinds for the virus, so we can identify people when they're infected, and for the antibody response, so that we can take people that have recovered, we won't be able to say for sure how many people have been infected. Right? And if we can't say for sure how many people have been infected, even if we're accurately reporting and counting the number of deaths due to COVID, we won't have an accurate CFR, because you have to have accurate case number and accurate fatality in order to determine that, right? So So, having said all of that, there are 7 countries that are over a 10% fatality rate. And I would like to emphasize that one of those 7 countries is Sweden. And why am I emphasizing that it's Sweden? Because there's a lot of people out there, again, in sort of social media land, but also entering my email box that are saying, hey, look at Sweden. Sweden isn't social distancing. They didn't shut down their schools. Their life is normal. Yes, and I say to them, look at Sweden. They have a case fatality rate of over 10%. Here in the U.S., we currently have a case fatality rate of just over, it's about 5.5%.
Okay.
And so that's twice as high as case fatality rates in South Korea and Norway. And both South Korea and Norway have been doing excellent in their public health management. They've been testing for viral infections. They've been isolating people who test positive for viral infection. They've been contact tracing those people have come in contact with, and they've been isolating those individuals. And so that is the appropriate public health response and the way that we should be taking action. That's the way we shut down SARS-1, is we identified what the animal reservoir was. The Chinese government shut down the wet markets. They collected those civet animals and they killed them by the thousands. Wow. And so they removed the animal. They removed the contact locality where the animals and the humans and the traders were coming in contact with one another. And then worldwide, as the virus spread across 27 different countries, we did isolation of infected individuals. We did contact tracing and isolation of contacts. And we did something called barrier protection or barrier nursing. And that's why all of the hype at the beginning was, don't rush out there and buy N95 masks. Save those for the healthcare professionals, because healthcare professionals are dealing with the most sick. They're the most vulnerable. And that's the only way to protect yourself from infection, to have something that's virus particles and fits appropriately. So it has to be worn appropriately. It has to be handled appropriately. And it's really only necessary for those who know they're coming in contact with infected people. And so for those masks to be scooped up by the general population and worn roughshod was really a waste of a precious resource. And so when we were saying, don't go out and buy N95 masks. You don't need to wear masks. Number one, we didn't know about asymptomatic spread. But number two, we also knew limited resource, and these are really critical for healthcare professionals. And so, and the general population is not going to be putting them on correctly, taking them off correctly, or wearing them correctly. And so they're really not going to be servicing you well either as an individual. So sorry, I think I got off. What were we talking about when I leapt onto that?
Well, we were talking about the CFR rate, and then a follow-up kind of question, obviously, is eventually, it's my understanding, one of the things that we look to see for something that is this widespread and this contagious is people are talking about herd immunity. Some have thrown in the number of 60%, things like that. I think true herd immunity has to be 90 to 95 in order to be totally effective.
So if we're talking about measles, herd immunity needs to be about 95%, but we're not talking about measles. So measles has
it's got an R0 factor that's a lot higher.
Yeah, it's got an R0 factor, which is the replication factor. How many people will one infectious person on average spread it to? For measles, it's over 10. I think it's close to maybe 15 for measles. Well, the R0 or the replication factor for this virus has had a couple of different estimates. The early estimates were about twice as high as flu. Now it may be an R factor of up to maybe 5 or 6, which is pretty high. But because for flu, it's between typically it's between 1.7 and 2 or 2.5 maybe, something like that for the average flu. But we know with SARS, the original, and SARS-2, this one, that there are certain people that are known as super spreaders. We don't know why they're super spreaders. And what does that mean? It means in the case of SARS-1, somebody apparently walked through an ER, and as they walked through an ER, they infected over 20 people in the ER just by passing through the ER. In this case, we know of one person in China early in the infection or early in the outbreak who passed it on to 13 other healthcare workers. We know of 1 or 2 infected individuals who arrived at a biopharma meeting in the Boston area at the end of February, and those one or two people in a 2-day meeting spread it to 77 other people, which was the beginning of the outbreak in Massachusetts. And so,
I'm thinking of the Washington State case where they held the choir practice, and one person had if 60 people attended the choir practice, one person was contagious, and over 50% of those attending.
Right. Yeah.
And that was odd too, because they tried to stay apart from each other, and they're trying to understand how that happened even with distance.
Well, again, remember, choir practice, you're singing, and if you're singing, you're projecting. And if you're projecting, that radius of need for social distancing is probably beyond 8 feet.
Yeah.
Right. And so that's probably, I hadn't heard of that one, but I mean, those things come immediately to mind, having sung in a choir and having directors say, project.
Yes.
Yeah, project if you're singing, but not if you're sick.
Yes.
So I know that there are a lot of people that are, like I am, we're weary with the sort of stay-at-home order. We're weary with not being able to be up close and mingling with friends. I certainly am. I'm a individual, although I'm an introvert. I've been in this environment for quite a long time. Even introverts have our outlets for extroversion, right, and those have been taken away from us. And so, I can't hug everybody Sunday morning at church. I haven't been to church in 5 weeks. I think 2 weeks before Easter, I think, is when they shut us down. And Los Angeles Diocese was pretty early, and Governor Newsom was pretty early to issue this stay-at-home order. And thank God, because that social distancing, certainly in the case of California, got us through flu season. And flu season is just now coming to an end. And so flu season typically ends the end of April, maybe the first week of May. And if we hadn't done what we did when we did it, then we would have been reaching worst case scenarios like we saw in Italy. Perhaps it's an older population, but our population's pretty old too. Or New York City, which might be more indicative of what we've seen. But again, New York City, it's a pretty compact urban area, right? And so again, the amount of crowding is going to increase the rate of transmission. And so places in Montana probably were never at huge risk. Maybe if an infected individual went into a bar in Montana and hung out with a bunch of other people, maybe 50% of the bar would have become infected, like 50% of the choir. But it's a bit frustrating, and I don't really want to open a different can of worms for people that are watching you necessarily, Lenny, but here I go anyway. So,
that's why we're here.
It's a bit like people who argue against the risks of vaccination, and they only have the luxury to argue against the risks of vaccination because of the success of immunization at a population level. And so now they can say, hey, well, I kind of assess the personal risk to me or my kids as too high in comparison to letting them out there into a mostly vaccinated and immunized population where maybe they aren't running that greater risk of catching this. It's kind of like people sitting here now frustrated from the isolation and really negatively impacted by the loss of jobs and unemployment and loss of income and instability, in addition to the stress of not having our normal outlets and social contacts as social beings. They're starting to say, hey, wait a minute, we didn't need all of these interventions. And these interventions aren't necessary. The risk isn't that great because these models haven't panned out. We don't have 1 million people dead in the US, right? No, but we have twice as many dead in the US as a normal flu season, and we're not through this yet. And we've been implementing social distancing and stay at home in some of the more crowded areas like Los Angeles County, where I live, or in the state of California. And so we've been successful, and successful to a degree that we really hoped we could accomplish to get us out of flu season. And it looks like we're making it out of it. And our hospitals haven't, for the most part, gone into crisis. And we're learning about how better to care for the critically ill in the hospitals. And so maybe not everybody has to go on a ventilator, or not everybody who's on a ventilator has to have a poor outcome, because we're learning even just simple things like flipping their bodies over so that their stomach down instead of back down actually opens up their lung capacity and increases the oxygenation in their blood and can get them off of a ventilator or keep them off of a ventilator. And so even just simple interventions like that in the hospital ICUs can have a profound effect on outcome. And we didn't know that when we started, and we couldn't have implemented it without discovering it, right? And so yes, we've been successful. Yes, the models have failed. We're not coming anywhere near close to that. But that doesn't mean we should conclude that the models were wrong. It means that we did what we needed to do, and the data that we generated from being successful is now saying, hey, those models were overestimates. I had somebody early on saying these global case numbers are absolutely wrong, and we shouldn't be doing any type of social distancing. This was somebody up in Canada who was sending me an email about this, and I was reading this thinking, oh my goodness, I don't know how to engage this individual, because I think this individual is wrong, and I think the information this individual wants to spread is dangerous. And so I said, okay, well let's assume this person's right. Let's assume that the global case fatality rates are grossly overestimated. Let's just go with normal influenza. And we know it's going to be worse than normal influenza, because normal influenza is in a partially immune population, either through vaccination or through underlying immunity. And so let's just assume influenza type levels for this. That projection, when I crunched those numbers for the US, led me to say the best case scenario, if this is just like a seasonal flu, is that we will have 52,000 dead in the US. We're over that number now, right? Yeah. So we've reached the best case scenario margin. And that's with all of the things that we've done. If we hadn't done all of these things, would we be looking like Sweden, where we have a 10% fatality rate? Possibly. Would we be looking at a situation where our hospitals were overrun and there was a shortage of ventilators? Possibly. Do we need to be cautious moving back into the fall once we come out of the summer, if we start to relax social distancing and see good outcomes to the relaxing of the social distancing in the summer months? Do we need to be that may take a burst in the fall when the temperatures start to get cool again? I would say yes. Keep your eye on the Southern Hemisphere right now. That's exactly what's going on there. Let's look at their numbers, right? So we need to be careful. We need to be cautious. We need to listen to the vast majority and the unison voice that comes out of the vast majority of public healthcare workers, virologists, epidemiologists, and infectious disease docs. And if you survey those four groups and you say, what is the common voice, not the aberrant voice, what is the common voice coming out of that collected group of professionals? That's the advice we need to be following.
Okay, so let me ask you, just to play devil's advocate on some of this. One of the charges, though, and I'm not talking about maybe rethinking the past, I'm talking about going forward, because everybody's like, well, we've distanced. How do we go out of it? We're starting to see ancillary effects, right? There's always unintended consequences for anything. We're starting to see effects in the food supply chain, for example. Domestic violence goes up, child abuse goes up. You have, I was reading an article from one lady who just graduated with her medical degree. She was doing a research project on pediatric immunity to something, and she says, all that's been pushed aside. We're all COVID scientists now. So there are lots of secondary and tertiary effects that happen outside of the question of loss of life as well.
Yes.
How do we, as well-informed people, weigh that? How do we as Christians weigh that? And my only hesitancy is there are so much specified learning in order to dig deep into virology or epidemiology or something like that. I don't know a lot of those folks have taken, say, ethics classes or philosophy classes that might help inform them on broader issues. So that's the concern.
You'll be surprised to hear that most people who have had medical training and or PhD training in any of those categories have had at least cursory training in ethics. There may be a complete dirge in philosophy training, but we've had at least cursory training in ethics, bioethics. It's required if you're a part of a nationally funded program. And so yeah, those are great questions, Lenny. And honestly, these are conversations that should take days amongst concerned individuals, because there's so many things that need to be discussed and not glossed. And I would say, we've never faced a pandemic of this nature before, and not to be overly dramatic, but if this had been H5N1, which is a type of flu that we've been worried about for more than a decade or two, at least a decade, we could be a lot more terrified right now. And so, you've probably heard some people say, this has pointed out some pretty severe systematic failures, not just in our response, but at a global level. And so I would say, okay, let's realize that what we're encountering right now is something unique. But let's not approach it as though, how quickly do we get out of this? But how do we think deeply about these issues? Because the chances are this may happen again, and it may not take 100 years. We've been very worried about an influenza pandemic in the scientific community for decades, not specifically the H5N1. We've been worried about whatever the next one was going to be for decades. And so I kind of look at this as, this is awful. But what if this is a practice run that's actually a grace of God, because something worse might be coming down the line, and it's helping us to start to grapple with this at a global and a national level, where we're like, well, we can't let our preparedness drop below that level again. We can't let our preparedness slack. And so, so these other questions and they're real phenomena, Lenny, and I acknowledge that. The depression levels in the U.S. were already very high, with billion-dollar economies in antidepressants on an annual basis. I think I heard recently that in the last month that the percentage of increased prescriptions for antidepressants increased by 40%. I don't know. I think I recall that number correctly. And so we're early into the social distancing and lockdown. Certainly domestic violence is going to be increasing when you can't get away and decompress. For me, on one level, I don't just want to pray specifically for the nation in those very desperate areas where we need prayer, but I also want to take action as an individual and encourage other Christians as individuals to say, I need to be reaching out to my neighbors. I need to be inviting them into safe communication. I need to be trying to assist them. One of the things that I've done, that I've had a very deep need, a felt need for community for a very long time in my life as a single. And I have long publishing community, and I've tried to be proactive in building community wherever I've been, and yet I've never had that sense of community that I've longed for. And I've always thought, well, gosh, what do I have to do? Do I have to go find a monastery, or do I have to practice some of the new monasticism where I'm living in community to get the kind of community that I want? One of the blessings for me out of this isolation is there are a lot of people feeling the same way that I've been feeling, and there are ways that people are starting to address those underlying needs through Zoom conferencing and community gatherings. And I know it's not the same, and I'll just reiterate, I miss my hugs on a weekly basis from people at church, and I miss the socialization with my friends and my tribe that I would hang out with, and from time to time. And for those in nursing homes, my mother's in a nursing home, and it's been on lockdown in Oklahoma for over 6 weeks. And again, it's like, oh man, my heart goes out to every patient in that nursing home. But what I've seen after 6 weeks is, my sister can no longer visit my mom and hug her and give her food gifts and candy, and I can't go to Oklahoma and visit her and tell her how much I love her. She's 90. She's probably not going to be around for much longer. She's progressing downhill for quite a while. But what I'm seeing there are other blessings. I mean, the sense of community that is developing amongst the patients and the healthcare workers in the nursing home, because those healthcare workers now understand in a new way that, you know, they have to care for these people, and they're the only people that can care for these people, and they have to be diligent in the way that they're caring for them, or else you can end up with dozens dead, because the nursing home is a very vulnerable population and a very close. Another blessing that's coming from that is that I now get to FaceTime with my mother. My mother couldn't operate FaceTime if you told her you'd pay her $1 million before this started. But because no one can visit, the nursing home has now set up appointments where you can schedule an appointment for FaceTime. They'll take a device into the room. They'll call you on FaceTime, and they'll hold it, or either assist the patient to hold it themselves. And I can now see my mom and talk to her the way that I'm talking to you. And so, although not about these in-depth conversations, but I can still tell her that I love her and I miss her. And so I think that there are creative ways that we can build community, even as we're having to readjust and socially distance. And I think as Christians, we need to be leading that forefront, because we have this deep compassion for those that we know are suffering, and to be able to just even offer our neighbors, maybe through a dropped off note or something, you know, if you need help, if you can't get out, if you need someone to go to the grocery store or the pharmacy, I can do that for you. And so we can serve and love one another in very practical ways.
I think that's great.
Yeah.
So I know we're getting close to the end of our time. Any closing thoughts that you would want people to know about as we kind of go on? The Governor Newsom has talked about in very broad strokes, a kind of an exit strategy. Not really clear yet when that's going to happen. As you said, we're at the end of the flu season, so hopefully in a matter of weeks we start to see some of these kind of restrictions lifted. But what are your thoughts going forward on this?
Yeah, I appreciate the opportunity to weigh in on this. Number one, I think we need the widespread testing, both for virus and antibodies, and I think we need that.
That's the data.
That's the data we need to be able to sort of regulate isolation and contact tracing and isolation, and that will be extremely, extremely helpful. But it won't be a be-all and end-all. Even with that in place, until we have something that approaches herd immunity, and I realize I never really addressed that number for you, but that number probably for this outbreak is probably around 80%. I've heard as low as 70%, and that makes me very nervous. I think 80% is still our best estimate at this point. We can get herd immunity because enough people become infected, but New York City, where it's been the worst, only about 25% of their population has been infected at this point. And so even where it's been bad, we're not near herd immunity levels. And so the social distancing, the face masks, we're going to have to keep that in the new normal pipeline for a very long time. But I actually think that can go a long way. I think that, along with hand hygiene, not touching your face, not touching anybody else's face, washing your hands for 30 seconds, soap and water, wearing the masks when you're out in public. I think if we're all doing that, and it really requires all of us, so it can't just be, I'm an American, I can be free, I don't have to follow this. But if we're all doing that, I think we can return to normal levels of activity relatively safely and relatively quickly. But if we're not doing that, we have to realize, if we're not all doing that, we have to realize there's a base level risk, and this can go very wrong, especially as we head back into the fall and winter months. So will we have mass gatherings like football? No, and that breaks my heart because I'm a huge football fan. Will baseball and possibly basketball return earlier than football? Maybe. Baseball is probably one of the safest sports for the people playing it, but you're still not going to have, and nor do I think we should have, large crowds until we reach herd immunity, or until we develop a vaccine, or until we have a drug sort of like Tamiflu or oseltamivir, where if you take it within the first 48 hours, or if you take it early on, in this case, when you become symptomatic, if you take it when you become symptomatic, it has a profound effect to help lessen the disease within, a week of taking the drug. Then maybe we can, once we have a vaccine or we have a drug that's that type of effective, then we can probably head back into a new normal. But a new normal is still going to be one where I think we're aware of sort of transmission routes
Yeah.
and how to protect ourselves. Before that, do I think that Georgia, for instance, is being irresponsible? I don't know how they're going to implement it individually at an individual level. I don't know how different businesses are going to implement it, but I certainly think it could be safe to go back into a barber shop. It could be safe to go back into a beauty shop. If I have a mask on, if my beautician or barber has a mask on, if we're not touching our faces or each other's faces, their hands are obviously clean. They just washed our hair and their hands in the process. So, those types of activities with those types of masks and social distancing where you don't have crowding in the beauty shop, I think that those types of activities could return. I think that, but I don't think I'm going to be able to hang out in my local pub anytime soon.
Okay.
Not safely anyway.
Right. All right. Well, thank you so much, AJ. I appreciate your expertise in this area. Hours gone by far too quickly. As you said, I'd love to dig into the nuts and bolts more on some of these things, but I want to be respectful of your time as well. Appreciate you and all at Reasons to Believe. Hopefully, as this again continues, we'll keep our eyes open. We'll definitely watch the South. We'll see what happens over the summer. I expect it to kind of wane, but then again in August, September, we don't know where that's going to lead us. But we'll definitely be keeping track on all this.
Lenny,
Thank you.
I really appreciate your work, Lenny, and I know those of us at Reasons to Believe really appreciate partnering with you every chance we get.
Absolutely.
As fellow apologists. I know that your fans, your followers are probably following you on social media, and I'll just say that I try to release responsible articles and information and commentary on my Facebook page and on my Twitter feed. And I try to always use the tag love boldly, serve wisely, think clearly, and pray always. And I just think that that's, again, some of the best advice that we as Christians can take to heart. You can find me through Reasons to Believe, both on Facebook and on Twitter. So.
Yes, and I'll put some links on the blog there as well. Okay, thank you so much, AJ. Take care.
God bless.
Yes, you too. Thank you for watching this Come Reason video. I hope you enjoyed it. If you'd like to see more videos like these, consider subscribing to our Come Reason YouTube channel by clicking on the subscribe button. And you can follow us on social media. Lastly, if you'd like to help keep these kinds of videos free, consider providing a donation by clicking on the donation button beside me. Thank you.